The hospitalized dementia patient with COVID. Good day. I would like to thank Dr. Shelley de la Vega and her team for inviting me to take part in this very worthy project. Since the start of the pandemic, I have seen more than my fair share of hospitalized persons with dementia who contracted COVID, and I have seen firsthand how difficult it is for the patient, the family, and even the medical staff to cope. It is my sincere hope that this module will help healthcare workers better understand, anticipate, and manage hospitalized persons with dementia and eventually improve their quality of life. Today, we will be discussing the challenge of caring for hospitalized persons with dementia, how we should engage the family early, how patients should be oriented and reoriented, how we should encourage independence, promote patient safety, anticipate and manage delirium and behavioral problems, use the DICE approach, and leverage information and communication technologies for the better management of our patients. Persons with dementia are vulnerable to COVID. They have difficulty understanding and complying with public health policies, as well as the proper use of personal protective equipment. Behavioral and psychological symptoms of dementia are common, such as irritability, hallucinations, aggressions, and sleep disorders, to name a few. They may be heightened during COVID infection and subsequent hospitalizations. Aside from these, persons with dementia once persons with dementia are admitted for COVID, they are more prone to experience delirium, which further leads to cognitive decline. Family members caring for persons with dementia should always be prepared for a diagnosis of COVID in advance. They should also make alternative plans for the person with dementia in a situation wherein the primary caregiver becomes sick or needs to be isolated due to exposure. They should make a list of all pre existing conditions, surgeries, allergies, daily medications, advanced medical directives, if any, special precautions, and even the triggers for troublesome behaviors. These would be very helpful should the person with dementia develop COVID and subsequently get admitted to the hospital. Once admitted, disorientation is common in persons with dementia. It will help to keep on reorienting them, where they are and why they are not at home, and who the medical staff on duty are. PPE for staff may scare them and heighten their anxiety. Healthcare workers should always introduce themselves first when addressing the patient and try to talk in a calm and reassuring manner. Always state every procedure simply and take care not to scare or surprise them. Worsening of disorientation and agitation may occur, especially in the late afternoon and early evening, and this is often referred to as sundowning. Try to open the curtains and blinds and let the daylight in so the patient can have a sense of day and night. Provide calendars, clocks, and pictures of family members nearby. Video calls with close family may also be helpful and alleviates loneliness and isolation. Hospital admission does not equate to total dependence on medical staff. Encourage and enhance current functional abilities for those who are still able. Just give cues when necessary and minimize the need for support. Most persons with dementia in the moderate to severe stage can still eat, bathe, and groom themselves as long as it is with assistance. For those with very severe dementia who are fully dependent, a caregiver will be allowed to accompany them in the hospital room. Basic infection control measures such as hand hygiene, frequent disinfection, Mask wearing and proper PPE donning should be gently reinforced for both the caregiver and the patient if possible. It is often impossible to reinforce this for very severe dementia, so social distancing should always be kept in mind. Persons with dementia are also at risk for falls and injuries, and precautions should be taken seriously. Every hospital room should be checked for possible hazards, including sharps, broken tiles, unsecured windows, and unsafe furniture. Provision for good lighting on walkways, corridors, handlebars in the toilet, and anti skid mats and shower chairs may also help reduce the risk. Always anticipate delirium and behavioral and psychological symptoms of dementia. Many factors push persons with dementia into delirium. The environment of the hospital is unfamiliar. They may lose sense of day and night, and they are very weak and ill. The staff are unfamiliar too, and their faces are not visible behind the mask and layers of PPE. They are also receiving various medications like antibiotics, steroids, painkillers, and sedatives, which can cause or worsen delirium. In COVID pneumonia, they often require oxygen via nasal cannula, face mask, or endotracheal tube for the ventilator, and food is given through a nasogastric tube in these instances to reduce aspiration risk. And they have various intravenous lines which cause discomfort and irritability. They often pull out their tubes in moments of confusion, leading to the administration of more sedatives. The list of behavioral and psychological symptoms of dementia are numerous, ranging from positive symptoms of aggression, agitation, irritability, disinhibition, hallucinations, and delusions, to the opposite, which is depression, anxiety, apathy, and sleep disorders. As in the care of delirium at home, the DICE approach is recommended. In the DICE approach, you just try to describe the troubling behavior, what, when, where, or who triggered it. Try to investigate, check the circumstances, the medication list. Always check for undiagnosed illness, pain, or hunger. Now try to create and develop a plan to tackle the troubling behavior and evaluate, assess how well the plan is being followed or how effective it is. For example, given a scenario of agitation, try to describe it. So the agitation is described as a motor agitation, wanting to get up and go home, pulling out the tubes, the oxygen masks and restraints. So try to investigate the circumstances. The patient gets more agitated with restraints. He feels suffocated with the oxygen mask. In the medication list, you saw that there was a quinolone recently added to steroids. And on suspicion and looking for undiagnosed illness, you saw that there are actually bed sores or pressure ulcers that are causing the patient pain. So then try to create a plan. So you may remove one restraint whenever the staff can hold one of their hands for brief periods. Try a nasal cannula or high flow oxygen. Reevaluate if the antibiotics are necessary or if they can be shifted to another family of antibiotics. Clean and dress the bed sores. Turn to sides every 2 hours and always change the diapers without delay. Now try to evaluate and assess the plan. As a last recourse only, do we give additional medications for agitation and make sure that standard dementia medications are on board. This is a problem as many persons with dementia who contracted COVID were actually previously undiagnosed and therefore not on standard dementia medications. Again, constant communication, reorientation, and reassurance are the mainstays of management. Lastly, information and communication technologies were literal lifesavers and frontliners in this pandemic. It allowed remote monitoring of real time vital signs and also lessened the exposure of the staff. Early on in March last year, only level 3 PPE were available for us to wear in the COVID floors. Hence, we had to use webcams and telephone calls to speak to the patient or caregiver, observe the readings on the monitors, and check on all the running drips. It lessened our exposure as we only had to do targeted physical and neuro exam at bedside and also reduced the use of PPEs. During confinement, there is indirect negative impact on the patient's physical, cognitive, and psychological functional well being. Every minute of being away from the usual environment without being visited by family or friends, the patient's overall health may be at risk for further deterioration. So, taking advantage of information and communication technologies during this period may help alleviate neuropsychological and social stagnation through audio and video calls to family and friends. Patients and their caregivers can also pass the time scrolling through social media, watching YouTube videos, and watching movies on Netflix. Multidisciplinary team and family meetings have also become possible with real time updates on the patient's condition, resulting in better communication and informed consent for procedures from the family. Lastly, after prolonged hospitalization, persons with dementia need conditioning and strengthening. And what better way to deliver these exercises and modalities than through telerehabilitation, where a rehabilitation medicine doctor, physical therapist, occupational therapist, speech language pathologist, and psychologist can assess, manage, and coach the patient from a distance. When conducted appropriately, rehabilit- rehabilitative and therapeutic services can be safe, effective, and beneficial for inpatients to prevent complications of physical inactivity. Telerehabilitation may also reinforce proper patient education and support to the caregiver when applicable. I hope that the short presentation was helpful in your everyday management and care of persons with dementia and COVID. Stay safe.